let's talk about those rare. Tell me what's going on with NCI-MATCH, and we'll also talk a bit about TAPUR.
Well, these are, ASCO is TAPUR is an ASCO-based match-like study.
First ever trial by ASCO.
First ever trial by ASCO. And there's an intergroup trial as well. So there are 3 large trials. Some are called basket, some called bucket. But basically, you screen tumors for every possible mutation. You try to find ones that you actually have a drug for where it's actionable. And so what it requires is that the NCI or ASCO or the intergroup have to get at least 5 or 6 or 7 hopeful companies together, so you actually have enough drugs to find enough patients. And what's happened in the MATCH trial, Stan Hamilton reported this at ECOG meeting recently, is that you're finding very few actionable mutations.
So is this why it shut down?
It was on hold, in part because they were overwhelmed with the volume. And now that's back up again because they've been able to overcome that problem.
And you said this earlier, but in that trial you have to do repeat biopsy, right? You have to send not the old specimen, but a new one.
In the intergroup trial, I'm not sure in MATCH.
No, MATCH you have to send new for sure.
Right.
Okay.
Up to three biopsies, if I'm correct.
Yeah. And part of that frustration has been the samples get sent, and then you find out 3 weeks later that you didn't have enough.
It takes
right?
6 weeks
Yeah,
to
and
find out.
It's got, I think the new mechanism is going to be in place. It's supposed to take up to like,
Yes.
I think 14 days now.
Yeah. So MATCH, TAPUR's a little different. It's more of a relationship directly with pharma and approved drugs, if you will.
That's correct.
Like HER2 targeted therapies, where if you find one, they'll get you the drug in exchange for reporting the information. So it is a clinical trial, but it's a much simpler clinical trial. Fewer data points, a lot less toxicity collection, that you get it, did it work or not, and then the hope is that that would ultimately extend indications. If we could prove that that works, HER2 therapies work for colon cancer in the right place, and they've extended it.
So it's going to get very complicated because we used to simplify things by saying you treat the organ from which the tumor came from, and then people said, we're going to totally change that. It's only based on the genomic pattern. But between melanoma and colon cancer, BRAF mutations occur, but in one, inhibitors work, and in the other, they don't work by themselves, although they may with EGFR combination therapy.
Yeah.
So it's more complex than we thought originally.
Definitely.
Part of my anxiety about all of this, though, is that even with a nation and ASCO and cooperative groups, for these rare mutations, that we're really not going to have the bandwidth to answer some of these questions in a timely enough fashion. So sort of my midlife crisis has been that we need it in an even larger scale on a national, on a global level. And so I'm really excited. Actually, I think every institution at this table is represented in this. Some members of your groups, Peter and Stan and Mayo in general, we're trying to work together where we've got a collection now of 35,000 new GI cancer cases around the world coming through the pipeline, if you will. And if we can profile all of those, then we, that rare tumor. I always like the example of, if you have a marker that's only 10%, let's say 10% of colon, BRAF or whatever, close to it, right? If you want a 50-patient study, I got to screen 500 patients. And if I want that in a year, that's 40-some-odd patients a month I got to screen. And so no big center or cooperative group can really do that. So we need to collaborate. So I'm really pleased that we're moving that forward. And it's kind of like the TAPUR study in that it's a collaboration between academia and industry.
And speeding the process of testing, of biopsying and testing in the MATCH trial, at least in the initial group, where they, I think, need about 30 patients per mutation to really get a sense of what would work or what would not work across tumor types, is most of these patients are not first or second line therapy. They're not at all. And so a lot of patients were never treated because they progressed while they were being tested and waiting for the result and waiting for the drug. So that has to be compressed into a very small time scan. Maybe it's good that they fell off, if you will, because maybe they shouldn't have been treated. But
and the good thing with MATCH is now instead of having 10 arms, they're going to have 23 arms. So that's going to be a big advantage, hopefully. And they actually reactivated the study just, I think, 3 days ago.
Right, yeah. They're going to screen 5,000 patients.
Yeah.
Here we go.
So they're hoping for 20% too.
The moonshot launches. If I find a BRAF positive patient, what should I do with them?
If you have a BRAF positive patient, refer them for a clinical trial.
Which is what's sort of hot right now?
Well, the SWOG trial just closed.
Right. So what have I got?
So there's some other trials that are under development, but I presume we're going to have other clinical trials as well.
So combination therapy, EGFR plus,
Yeah.
inhibitors and things. Anybody
Kathy,
got any?
remind me of the SWOG trial again.
The SWOG trial, so it was a randomized phase 2 study. It was the control arm is irinotecan cetuximab second line, and then the investigational arm is with the addition of vemurafenib.
So before we move on to sort of managing metastatic disease, you know, over the last couple of years, we've seen an emergence of categorizing colon cancer by different molecular profiles. And we're talking here at ASCO about how that reflects in anatomy, actually. So is anybody here doing broader profiling yet to try and put them into one of the 4 molecular buckets that are out there, or is that not quite ready for the, you know, the TEJPAR sort of analysis? Is anybody there yet?
Well, I don't think that analysis is there yet for us to be there yet with it.
Of how that would affect clinical
I
outcome?
think it still needs to be looked at, you know, in wider data sets and be confirmed before it makes sense. It could be just a prognostic, you know, a bucket list rather than actually help us direct, you know, what type of therapy. It's useful, but I think more work needs to be done. And for the day-to-day applicability, it's not there yet.
Where we're going, but we're not sure where we're going to be.
We're not sure where we're going to be.
It's
with it.
thought-provoking.
It is.